Morrone, owner and wealth manager at Nexa Financial Group, and I'm joined here by Mark Brownstein of Emerald Medicare. And we're here to talk about all things Medicare. Open enrollment is coming up, and we want to just talk about some of the challenges of this year's season, some of the changes that are coming through, and things that you really need to be aware of as we go through this process as you look to your renewals or maybe even enroll for the first time. So, Mark, thank you very much for being here this morning.
A pleasure to be here. Always an honor to educate recipients or future recipients of Medicare.
Awesome. So we'll jump right in. And, one of the things that we always do is field questions from our clients, but I'm really curious, what kind of questions are you getting from the people you're speaking with as, on the cusp of this open enrollment season? And, how are you advising them on those?
So the changes that started in 2025 that people may or may not have noticed, or they were subtle, are really impacting all areas of Medicare. And so if you think about what's called Med Advantage plans, Part C and Part D, if you think about Medigap plans, also called Med Supplement, if you talk about Part D and prescription drugs, all of them have been impacted by the Inflation Reduction Act. The Inflation Reduction Act did one major impact, which was that for the medication costs that any individual can bear for the entire calendar year, in 2024, the number was $8,000. In 2025, it was reduced to $2,000. That created shockwaves across every aspect of the Medicare industry, because all of a sudden, the carriers had to absorb more of the costs for some of the prescription drugs. And so the carriers had to make significant adjustments. Some of them made actual adjustments after open enrollment started because they were that nervous. So prescription drug costs for some have gone down, but prescription drug premiums have gone up for those people who have a standalone plan. For those people who have an Advantage plan, Part C and Part D, the benefits have begun to go down. And so, for instance, if you're looking at dental, if you're looking at eye care, if you're looking at maybe hearing or gym membership, those benefits are slowly inching downward because of the price pressures that are being felt. So these are changes that happened in 2025. 2026 is, we're still in the eye of the storm. I have to be honest. We are gearing up, preparing ourselves, bracing ourselves for an incredible season of change. People get in their mail what's called an annual notice of change, and many people don't read it, and hopefully they call their broker to talk more about it.
And you answered one of my questions where there's no free lunch in this. So if there's going to be a benefit had by the policyholder, someone's absorbing that cost, and it could be the policyholder in an indirect way, like you said, a curtailment of benefits, higher copays, something like that. So that brings me to another question in terms of just the changes that were coming through, started last year, really coming through to this year, and what people might be seeing in those notice of change letters, at least in your experience, that they may miss if they're not reading things carefully or talking to their broker.
So again, it's subtle changes, and each year it's going to be more subtle as the carriers determine their profitability in terms of whether they have what's called a loss ratio. A loss ratio, it really determines their profitability, and ultimately is what they have to report back to the Department of Insurance to request premium increases. But one of the big changes that are going on is the fact that PPOs are being phased out. They're being phased out because a PPO, by definition in the Medicare world, allows people to go outside of their HMO network. As many people know, the larger medical institutions are consolidating a whole lot and putting everyone under one roof. So all the primary care, the specialists, the surgery, even the hospitalization is under one roof, which means they can control their costs. So many carriers are actually eliminating PPO plans so that they are actually forcing people onto HMO plans. In some cases, they are keeping the PPO plans, but they're eliminating compensation for brokers. In some cases, they are actually moving people over to an HMO or another plan that's being terminated without really their knowledge. Well, no, they have knowledge, but they're not necessarily responding or inquiring on what is best for them.
So it's more
It's
of a negative consent process.
right. It's if you don't respond, this is the change that's going to occur. The phasing out of PPOs is a big change to the marketplace. HMOs are really the way to control costs, and this is things that it started in 2025 and is continuing in earnest in 2026.
So that leads me to another question then. And when you're looking at these notices of renewals, or you're talking to someone that maybe has a previous Medicare plan and they're looking at open enrollment this year, what's the biggest catalyst you see to recommend a change to their plan? Is it something in their life? Is it the plan that they have has just been diluted where it's not as good anymore? Combination of them? Or do you see one or two things that's like a red flag that you say, oh, we got to go somewhere else. We got to maybe pay a little more for a better plan or something like that?
So great question. And, is grass greener on the other side? A lot has to do with health and budget. And so people's budget is a big determining factor on whether they can absorb out-of-pocket cost or premium increases or copay increases. And so when people look at their premiums and they look at their out-of-pocket costs, and or if they have some way of looking at that over a given calendar year, some people are actually looking at going one way or the other, either changing to an Advantage plan from a Medigap or changing to a Medigap from a Med Advantage plan. They're opening their minds to the possibilities of a change. The important thing to note is that in Connecticut, Massachusetts, New York, and Maine, those are the only 4 states in the country where you can actually have these Advantage plans, which for many people work very, very well. And you can switch to a Medigap plan without any health questions, underwriting, or pre-existing conditions. That gives people in those states tremendous flexibility of having the conversation with somebody who is looking out after their best interest to determine if, at least for a year, to try out one or the other. Some people's health has changed and they feel like they need to and have to be on the Medigap plans. Some people have been spending a lot of money on premiums on the Medigap side. Their premiums have gone up in some cases 10 to 20%. And they're saying, you know what, I'm good health. I'm going to try an Advantage plan. I'm in one of those states. I can change in the future.
So is that one of the scenarios where, heaven forbid, it's January or February of a year and you get a really unfortunate diagnosis that's going to cost a lot in ongoing care, possible surgeries or something like that, where you can actually switch to a better plan in hopes to get more of your services covered?
So the answer is both yes and no. If it's in January through March, there's a special enrollment called OEP, Open Enrollment Period, where in the month of January, February, and March, you can change for the next month, especially in Connecticut here, so that you can actually change without any health questions to a Medigap plan. If it happens after March 31st, you actually, on an Advantage plan, you are in that plan for the rest of the year. The maximum out of pocket on these Advantage plans is around $9,000 and inching up. But the only way to get to that number is by having multiple hospital stays or multiple surgeries. So the first 3 months of the year, people can actually switch from an Advantage plan to a Medigap plan, though you cannot switch from a Medigap plan to a Med Advantage plan during those 3 months. And you can't change your prescription drug plan. So there are some limitations. If something happens early in the year, my comment is generally, Paul, is that people should always call their broker because there are special enrollments based on flooding, hurricanes, fires, FEMA-related
Gotcha.
activities where people can actually make a change because the government or the carrier are allowing for special enrollments. So I would always say people should call, especially, again, in those states that I mentioned where people have the flexibility. So one other thing I'll add is that you can actually change to a Medigap plan any time of the year. to answer your question more directly, but you can't change your prescription drug plan any time of the year. So that puts people at risk and vulnerable for not having a prescription drug plan potentially if they have something happen in June. So they can switch to a Medigap plan, but the prescription drug plan would make them vulnerable.
Awesome. And, a lot of these conversations that we're having now are centered around out-of-pocket costs. And, when an individual's on Medicare and generally, someone like you said, in good health, the Med Advantage plan may be fine. But for those that, maybe are on some expensive prescriptions or just need to receive a higher level of medical care, what do you often see as the biggest, we'll say, out-of-pocket expense that someone will bear when they're on a Medicare plan? Aside from long-term care, which is kind of beyond the scope of what we're talking about today.
Right. So, speaking of long-term care, people often think that Medicare is going to handle chronic conditions where it actually doesn't. But the biggest impact actually is related to that, and that is in a rehab scenario. So people are hospitalized or they have surgery and they're going into rehab. On the Advantage plans, they're limited to 20 days. And really, after 10 days, you are hearing from someone at the facility, sort of letting you know that your benefits are likely to run out shortly. And they're encouraging people to move over to original Medicare, which is fine, but they're not necessarily recommending, especially in those 4 states, including Connecticut, that they can move to a Medigap because they actually often don't know. These case managers and social workers don't know. But if in fact they are moved over to original Medicare, or even if they stay on their Advantage plan, they're paying about $200 a day once their 20 days runs out. And so if they're on a Medigap plan, and let's just call it they're paying $250 a month, after the first 2 days, they've just saved a lot of money. So the biggest cost on the Advantage plans are going to be 3 things: hospitalization, surgery. Those 2 things separately can cost between $1,000 and $2,000 maximum. So it's not unlimited. There is so it's usually the first 4 days, the first 5 days, or the first 6 days. Days, let's call it 6 through 90, are covered, no cost. But the first, whatever, 4 to 6 days could cost between $1,000 and $2,000. On the other hand, the other big piece that I just mentioned is the rehab piece. And that's where it's hard to predict something like that. We get calls all the time at the end of the month from people who are adult children who are aware of the fact that they are being asked to change away from their Advantage plans. And especially in those states, we can help them, and they are completely grateful.
So it sounds like there's a major difference especially with the rehab scenario, between a Med Advantage and a Medigap plan. So could you talk
Right.
about that a little bit?
Sure. The Medigap plan offers up to 100 days. And so 100 days is quite a bit for rehab. People
Sure.
really don't
Yeah.
stay that long. They're really, if they're moving into a facility rehab, again, 20 days is short. 100 days is, you don't often need that because then you're either back home or maybe in a nursing facility. And that's where long-term care insurance picks up. But the other big cost, again, is the prescription drugs. And so now that the maximum in 2025 is 2,000, going up to 2,100 in 2026, that's the biggest cost. And so that cost alone, is an impact. But the government has actually implemented a payment plan. So if somebody knows that they have an expensive medication, and usually they have a deductible of $590 in 2025, $615 in 2026, they have to pay that initial deductible and maybe some more costs because of the high tier. But the government has implemented a payment plan, which means that you can spread the cost of your medications over a 12-month period of time. So 2,000 divided by 12 is $167 a month. You can spread that over time. It doesn't include the premium cost for the standalone prescription drug plan if you're on a Medigap plan. So the cost of medications used to be up to $8,000. Now it's less, but all of those 4 things that I mentioned are all impact on people's ability to afford healthcare.
Great. And, speaking of 2026, you had mentioned the deductibles on the prescription drug coverage. And I don't know if you've even seen this yet, but as far as the plan pricing goes for 2026, I know we've seen the Medicare Part B premiums come out. Have you seen the pricing for the supplemental plans, and how do those look relative to last year? Are they still in that 10 to 20% increase, or have that not been released yet?
So a couple of things there. One is the $257 Part B deductible is going up to $288. The Part B premium for people under the income level from 2 years prior of 106 for single and 212 for married couple. That baseline of 185 is going up to 206.50. So those are sort of costs that will be incurred. And the table for the IRMA, that table isn't out yet, and that those increases will be there as well. But in terms of price increases, I want to sort of make sure people understand that, again, because of the Inflation Reduction Act, what has been the historical component of all the carriers all across the nation, the average increase from year to year was 4 to 6%. Because of the Inflation Reduction Act, because of all the things that might be going on with the government, healthcare, denials, fraud, those increases are between 10 to 30%. In addition
Wow.
to that, some states change their rates at different times of the year. So in Connecticut, it's once a year. It's not in January. They try not to do January because that's connected to open enrollment. So in some cases it's April, in some cases it's July, and so yes, there are price increases. People are looking again at alternatives. These Medigap plans that are, let's call them $250 a month on the average. There's Plan G, there's Plan N. There's a high deductible plan that has a $2,800 deductible. That is, let's call it $90 for the moment. And so that's a much lower price plan but they get 20% copay for every service that they use. So when you do the math, these high deductible plans may work. People have to really begin to evaluate what their options are. But in the states that I mentioned, including Connecticut, the flexibility exists to try something different and see if it works. Many people stay the course. They're nervous of change. They don't have a reliable, independent broker who's going to look out after their fiduciary responsibilities, so they stay the course. But with these premium increases, the expectation is that many more people will be looking and reviewing.
Excellent. And, I really appreciate your insight today, Mark, and for all the advice you provide, not just to us as a resource, but to our clients. And we'll be sure to include your contact information following this video for anyone that wants to reach out to you in this very timely time of year. So I wish you all the best during open enrollment, but thank you again for your time.
My pleasure. Thank you very much. And to all, a safe time of the year.
Excellent. Thanks again, Mark.
Thank you.